Hello, and welcome to Salinas Valley Memorial Healthcare System's virtual Ask the Experts event here on Facebook. My name is Christiana Kearns, and I'm the Senior Administrative Director of Cardiovascular, Pulmonary, Sleep Medicine, Nutrition, and Rehab Services at Salinas Valley Memorial Healthcare System. It's February, and that means it's Heart Month. It is my pleasure to introduce you to our expert cardiac electrophysiologist, Dr. Harlan Grogin.
Thank you, Christy.
Dr. Grogin, thank you so much for being here today. Dr. Grogin joined Central Coast Cardiology and the medical staff at Salinas Valley Memorial Hospital in 1995. He established our cardiac electrophysiology program, and he is also the medical director of that program and cardiac rehabilitation services. Today, Dr. Grogin will be focusing on atrial fibrillation with ablation and on the Watchman implant. The Watchman device is an FDA-approved device which is permanently implanted in the heart to help reduce the risk of stroke. Salinas Valley Memorial Hospital was the first hospital in the Tri-County area to provide this service in this non-surgical procedure. For those of you watching, if you have any questions throughout the presentation, please use the comment box below, and we'll dedicate time at the end of the presentation to answering your questions. All right, Dr. Grogin, take it away.
Thank you, Christy, and thank you everybody for being with us today. Happy Heart Month and happy Valentine's Day this Sunday. The first topic that I'd like to talk to you about today is something called atrial fibrillation, which is the most common abnormal heart rhythm that a heart electrician or electrophysiologist deals with. So in our first slide, we have a cartoon of what atrial fibrillation is. Atrial fibrillation basically is an electrical problem of the heart. So the heart muscle pumping is okay, just like your car engine is working fine. The gas is getting to the engine, so this has nothing to do about the arteries or the blood getting to the heart muscle. So what atrial fibrillation is the wiring of the heart. People can go too slow or too fast or both. It just depends upon what the problem is. In atrial fibrillation, in the slide on the left, you can see there's the metronome for the heart, the sinus node. The sinus node keeps the rhythm for the heart, sends an impulse down to the middle. From the middle, it goes down to the bottom. So if you look at the heart, when you're in a normal rhythm, the top and bottom work together as a team in a one-to-one relationship. There's teamwork. In atrial fibrillation, as you see on the right, the top part of the heart is going kind of crazy. The top part of the heart is going 300 or 400 beats a minute, and every little muscle cell is working on its own. And so the top is going kind of crazy and the bottom is going kind of crazy. This chaos or loss of teamwork between the top and bottom part of the heart causes the symptoms that people can get with atrial fibrillation. The symptoms that people get with atrial fibrillation can include getting dizzy or lightheaded or short of breath or just feeling anxious and not feeling well. What causes atrial fibrillation? And atrial fibrillation is a very common abnormal heart rhythm. Probably about 10 or 15% of the population over the age of 70 have it. So as we get older, it's a natural problem to have this atrial fibrillation, this arrhythmia. It can be caused by multiple things as demonstrated in the slide. People can have heart failure, they could have lung problems, they could have valve problems, coronary artery disease, high blood pressure, something called sleep apnea. Unfortunately, it's also exacerbated by too much alcohol. So when you treat atrial fibrillation, you can't just treat one of those things. You have to treat all of them. It's a multifactorial process. The other important thing I'd like to talk about with atrial fibrillation is that it's kind of develops over time and gets worse over time. So when people start having their initial symptoms or documented arrhythmias of atrial fibrillation, it's called paroxysmal atrial fibrillation. It's usually just lasts 2 or 3 days. It can go away by itself. And a lot of times people feel irregular heart rhythms. They're not sure what's going on, and then it goes away. So when atrial fibrillation is in its infancy, the top part of the heart is usually normal in size, and atrial fibrillation episodes can be brief. Over time, atrial fibrillation progresses. So episodes last from seconds, they start lasting hours or days or weeks. This is persistent atrial fibrillation. And when you're in atrial fibrillation and it's persistent, it doesn't just go away by itself. Sometimes people need a cardioversion where they're shocked back to a normal rhythm, or they need drugs, they need medical therapy to return them to normal sinus rhythm. And again, over time, if the top part of the heart is going kind of crazy, the atrium gets bigger and you get more scar tissue in the top part of the heart. And that leads to more persistent atrial fibrillation. And if the persistent atrial fibrillation is not dealt with, then you get more scar tissue and the top part of the heart gets even bigger. And then you can wind up being in permanent atrial fibrillation where you're in it all the time. So again, I would like to address the problems with atrial fibrillation. And one of the things that we'll come back to later when we talk about the Watchman procedure, the most frustrating thing about atrial fibrillation is that the risk of having a stroke. So again, when you're in a normal rhythm, the top and bottom work together as a team, and the top muscle is pushing the blood to the bottom. When you're in atrial fibrillation and every little muscle cell is working on its own, the blood can kind of sit around, become stagnant, and get a little clot. If that clot goes to the bottom part of the heart and then gets squeezed out, you can have a stroke, which is the most devastating complication of atrial fibrillation. So to prevent people from having strokes from atrial fibrillation, we try to prevent them from having strokes by putting them on blood thinners. The other problem, as I mentioned, with atrial fibrillation besides strokes is the symptoms that people get from losing the teamwork between the top and bottom part of the heart. Sometimes people are not even aware of their atrial fibrillation. They actually have no symptoms. And if people are in atrial fibrillation for a long time and not aware of it, they can actually present with a stroke because since they were never aware of their atrial fibrillation, they get clots and then present with having a stroke, and they never even knew they were in atrial fibrillation, which is obviously very frustrating. In some people, if they present very late in their atrial fibrillation and they're doing well, we just try to control the heart rate so the heart muscle doesn't get weaker over time, and we control the heart rate so it doesn't get weaker, and we also put them on blood thinners so they don't have a stroke. But the major reason we see people with atrial fibrillation is that they get symptoms. As I alluded to before, people can get dizzy or lightheaded, short of breath, or feel anxious. So we want to get those people back into a normal rhythm. There are two ways of getting people back to a normal rhythm. One is with antiarrhythmic drugs, pharmacotherapy. The other procedure, which I'd like to talk about, is something called catheter ablation. Drugs or pharmacotherapy for atrial fibrillation, at best, works 50-50 at the end of 1 year. So they're not very effective in the long run. And even if you do take drugs, and there are many antiarrhythmic drugs, even if you do take drugs, you still have to take anticoagulation to prevent you from having a stroke. You can't depend on those drugs working forever and keeping you in a normal rhythm. And studies have shown that even if you take a drug, to keep you in a normal rhythm, you have to stay on a blood thinner. So again, just to highlight, because I'm going to be talking about the Watchman procedure, again, when to try to assess whether somebody really needs to be on a blood thinner or not, there are multiple scoring systems. So the older scoring system is called the CHADS-2 risk score. And those are the first letter standing for people who have congestive heart failure, hypertension, if you're over 75, if you have diabetes, if you have a stroke. And for each of those risk factors, you get a point. And the more points you have, the higher the risk of having a stroke. So if you're 75 and have a history of hypertension, your risk of having a stroke is probably at least 3 to 5% per year if you don't take any blood thinners. Whereas if we put you on a blood thinner, the risk of having a stroke is less than 1%. The CHADS-2 risk score was actually updated a few years later to become more encompassing, and that's called the CHADS-2 VASc score. And there are a few other items that were added to it to make it more comprehensive, such as if you're over 65 rather than 75, if you have other vascular disease like a heart attack or high cholesterol or other vascular, peripheral vascular disease, or if you're a female. Sorry about that, but those are the data, the science. Also, obviously, when you're put on blood thinners, there's a risk of bleeding from the blood thinner. So there are the pros and cons, risk versus the benefits when you put on any medication. When you put on a blood thinner, it's great that it prevents you from having a stroke, but there's also the risk of bleeding. And those are the risks of increased bleeding, again, if you have hypertension, high blood pressure, if you've had a previous stroke, if you're older, or you have other drugs like non-steroidal, for arthritis or something like that. So there are recommendations out there for people who need blood thinners. So if you're young, if you're 35, 45, or 50, and you don't have any risk factors, you don't have high blood pressure or valvular heart disease or diabetes, theoretically your CHA2 VASc score is 0. The chances of having a stroke is very low, then people can be treated with aspirin. But again, the point I'd like to make is once you have more than 1 or 2 points, if you're over 65, have high blood pressure, if you have sleep apnea or any of those other causative agents for atrial fibrillation, you would benefit from being on a blood thinner to prevent you from having a stroke. So again, in summary, when we approach people with atrial fibrillation, again, one of the most important things is deciding whether people need to be on anticoagulation. And I just wanted to make sure that we emphasize that, and we'll come back to that again. And now I'd really like to talk about the best way to keep people in a normal rhythm, or what we call rhythm control. So ways we have of getting people back to a normal rhythm are putting them on drugs. And if the drugs don't work, we can shock them, like we've all seen on TV. They run up and say, clear, and they cardiovert people back to a normal rhythm. So that's what a cardioversion is. Now, a cardioversion doesn't fix the problem. It just temporarily gets you back into a normal rhythm, but you still need your drugs. So what I'd like to talk about next is what I think, obviously, as a heart electrician, a better way to keep people in a normal rhythm, and that's catheter ablation. So if you look at the heart, the blood comes back from the lungs to the heart. So you have the right lung, you have the left lung. There are usually 2 veins from the right lung, 2 veins from the left lung. So there are usually 4 veins which bring blood from the lungs back to the heart. Those are called the pulmonary veins. And it's electrical short circuits on the lung side that get into the heart that create this electrical chaos that causes atrial fibrillation. So if you look at the diagram, you can see that there are 4 pulmonary veins: the left upper, left lower, right upper, right lower, and they're circled there. And again, it's electrical short circuits in the lungs that get into the heart that create this electrical mischief. So theoretically, if you could put duct tape around those veins and prevent those electrical impulses from getting into the heart, in most people we could actually cure or alleviate most of their atrial fibrillation. And the chances of success with a single atrial fibrillation ablation is usually quoted as about 70 to 80% for one procedure, which does mean that 20 to 30% of people may need a second procedure. So it's a very common practice that people will need a second procedure for their atrial fibrillation. The other thing I would like to mention is that the sooner that we can do an ablation on somebody, usually the rate of success is higher. So in other words, if you can do an ablation when the left atrium is normal in size, when the atrium is still, like for paroxysmal atrial fibrillation, the risks are much higher than if you wait until there's more scar tissue, or if the atrium is bigger for like permanent or persistent atrial fibrillation. So if you can get to a patient within the first year of their diagnosis of atrial fibrillation, they'll do much better with an ablation than if they don't have it. So in other words, what I'm trying to say is, if you have people who have atrial fibrillation, you can either have an ablation, especially if it's early on in the course, like if they're paroxysmal, or you can not have an ablation. And the people who have the ablation do better in the long run with less atrial fibrillation, less symptoms from their atrial fibrillation, less hospitalizations. Now, I'm not going to say the data do not support, I can't say you will live longer or never have atrial fibrillation again. But for people who have symptoms, the data suggests that doing the ablation sooner is much better for those patients. So I'd like to go back to the risk of having a stroke with atrial fibrillation, and I'd like to talk about the Watchman device. Now, as I mentioned, with atrial fibrillation, we want to prevent people from having strokes, so we put them on blood thinners. And those blood thinners, as I said, also can increase the risk of bleeding. And so it's always a double-edged sword. We want to prevent strokes, but we don't want people to bleed. So a lot of people do get blood thinners for the atrial fibrillation, but because they're falling, they're older, they use canes, they're in a wheelchair, or they have GI bleeding, they have ulcers, they have imbalance issues, or sometimes people will come to us and say, hey, you know, I'm 60 years old, I go skiing all the time, I go windsurfing, I go water skiing, I don't want to be on a blood thinner, I'm just going to hurt myself if I fall or hit my head. And so for people who need to be on anticoagulants for atrial fibrillation, but they can't take the blood thinner because they're bleeding or falling, the Watchman device is like the perfect device. We'll discuss that after the little video that you'll see now. So as you see in this picture, you see the left side of the heart on your right side of the picture, and that's called the left atrial appendage. As I mentioned before, the left atrial appendage is sort of like a little pouch. And so if the top part of the heart is not squeezing well, you get little blood clots that form in that pouch and then get into the heart and then can go and cause a stroke if it goes to the head. So if we could sort of isolate that left atrial appendage, if we can prevent those little clots from getting out of the heart, then we can prevent you from having a stroke. So what this procedure is we go into the heart, as you saw, and we put in this little kind of an umbrella mesh device that's made out of nitinol, and we put it in that left atrial appendage. It gets covered with tissue over the next 45 days, and then after 45 days, we go back and take a picture or a transesophageal echo to make sure that that left atrial appendage is entirely sealed off. And then once we know it's sealed off, we stop the blood thinners. After 45 days, you can come off of the blood thinner, and then you can be on aspirin and Plavix for about 2 months, and then aspirin only. So on the next slide, again, I just want to go over the indications of the Watchman device. Again, if you can't tolerate blood thinners, like Coumadin, Xarelto, or Eliquis, which are excellent blood thinners, but you can't take them, I think the Watchman device is indicated. And as you see, again, to get a Watchman device, you have to have a CHADS-2 or VASc score of 2 or 3 or more. But again, because of bleeding issues, because of falling issues, because of lifestyle activities, people decide that they are not good candidates for long-term anticoagulation. And then on the last slide, again, you can see that little Watchman device goes in that appendage, closes it off, and thus we don't need anticoagulation anymore. The procedure itself takes about an hour. We usually keep people overnight, again, just to make sure there are no bleeding problems, and then they go home the next day. So I think that if I had to just sum up my bullet points for atrial fibrillation, I'd like to just make people aware that there are stages of atrial fibrillation. There's paroxysmal, more persistent, and then chronic or permanent atrial fibrillation. I think for patients who really want their atrial fibrillation cured or to have less symptoms, then you really want to deal with it sooner rather than later. And the effectiveness of catheter ablation for atrial fibrillation is highest when you get to it within the first year, and it's really a great procedure for people who are symptomatic. They may need a second procedure, but I think clearly those people with symptomatic atrial fibrillation do better with an ablation than rather drugs alone. It's also indicated in patients who have heart failure, and there have been studies that have been shown that for people who have heart failure and atrial fibrillation, there's a better chance of getting those people back to a normal sinus rhythm and keeping them there if they have an ablation than if they don't. And lastly, with the Watchman device, again, for people who can't tolerate blood thinners or for lifestyle reasons, a Watchman device is a great and very satisfying procedure to do. We've done these procedures on people who are in their 60s because of lifestyle reasons. We've done these procedures in people who are 90, 95 years old and can't tolerate blood thinners for multiple reasons. And the Watchman procedure itself is also getting safer and safer. They're coming out with a newer generation of the Watchman device, which has just been FDA released a few months ago. So Christy, I think I said a lot in just a short time, and I'd be delighted to answer any questions that people would like to ask.
Excellent. Yes, we actually have a question from the audience. Lisa Sieniki, I hope I didn't destroy your last name, Lisa. So she says that, the first time she learned about the Watchman device, she was completely blown away, and she's wondering, does it ever dislodge?
An excellent question. I don't know how well you can see this little device here, but the Watchman device, like I said, if you can imagine an umbrella that opens up, and then the umbrella prevents the clots from getting out into the left atrium and then out of the heart. But they're kind of little spikes that hold that Watchman device in place. And when we put in the Watchman device, we actually have multiple measurements. And like you're alluding to, does it ever come out? Well, not everybody has the same size left atrial appendage. So the left atrial appendage devices come in multiple sizes, anywhere from 21, 24, 27, 30, 33 millimeters. And so we make multiple measurements during the procedure and to find the right size of the device. Once we put in that device, we do actually pull on it. It's called the tug test to make sure that that device is stuck. So once it goes in, the chances of its dislodging are extremely rare. Hopefully that answers your question.
Excellent. We have another question. How old is the youngest person you've implanted the Watchman device in, and how about the oldest?
Well, again, as I mentioned before, I've done people as young as 60 years old because of lifestyle choices. They're competitive triathletes, cyclists, and they ski, and they just don't want to be on blood thinners, period. For some people who are that young, what I actually urge them, if feasible, is to get an ablation to try to help keep them in a normal rhythm. And once they recover from that, consider the Watchman device if it's still needed. The oldest person, we do multiple people in their 90s, and I think we've done somebody 95 or 96 years old. They were out of the hospital the next day, walking around. Again, I just want to emphasize that for 45 days, people do have to go back on their blood thinners. And then 45 days later, we do go and look with a transesophageal echo just to make sure that that device is functional. In other words, that that left atrial appendage is entirely sealed off, and then we can stop the blood thinner.
So also, if a person has already suffered a stroke, are they still a candidate for the Watchman implant?
Yes, the question is, again, if people have a stroke, are they still a candidate for the Watchman device? Now, sometimes people have strokes because they bleed into their head. And so clearly, a lot of people don't want to go back on a blood thinner because they're afraid they're going to bleed in their head again. And so also people who have strokes and put on their blood thinners, again, they still wind up with those issues. They can be falling, their lifestyle choices, they don't want to be on the blood thinner, they have bleeding issues. So once people do recover from their initial stroke, we do go back and do the Watchman procedure so that eventually we can get those people off of anticoagulation. I should just say that some people say, oh, can I get a Watchman device? I'm on blood thinners and I don't want to be on them. but the reason why they're on blood thinners is for another reason besides atrial fibrillation. So in other words, if people have a mechanical heart valve, they need to be on the blood thinner for that valve, not because of the atrial fibrillation. Or if people have blood clots in their lungs, pulmonary emboli, or if they have clots in their legs, a DVT, unfortunately, the Watchman has nothing to do with those indications. Okay, the Watchman device, again, is only to prevent people with atrial fibrillation from having strokes so we can get them off of anticoagulation, but they can't need their anticoagulation for other reasons.
And about how many of these procedures have you performed so far at the hospital?
The Watchman device has been around for a few years, and as I mentioned, another generation is now being FDA released. We started doing this at Salinas Valley Hospital about 2 years ago, and so far we've done between 50 and 55 devices without any complications, without any major complications or bleeding. I think there are a lot more patients who would benefit from this procedure, and I think it's one of the more rewarding procedures to do to get people off of blood thinners when they're not great candidates for it.
Excellent. Thank you so much. Other question from the audience is people are wondering if they can make an appointment with you to discuss this implant and if they need a referral to do so.
We're available for atrial fibrillation ablations, for Watchman procedures. We do have a coordinator. Her name is Ann Timberlake, so you can call Ann Timberlake or call our clinic or the hospital, and obviously we'll put you in touch with the right people.
Excellent. Thank you so much, Dr. Grogin. Do you have anything else you'd like to add about heart health and during this COVID-19 pandemic?
Well, I think that the COVID pandemic has to be taken very seriously, and a lot of people are afraid of being in hospitals for cardiac procedures during this time. But a lot of cardiac issues, having heart attacks or valve problems or strokes, are issues that don't go away just because of COVID. And so I don't want people to not pay attention to their cardiac symptoms or think it can wait until COVID goes away. And I also like to add, I think everybody should get a vaccine if they can, and obviously wear a mask. This is not natural that we're not wearing masks right now, but we wear this all the time, and I think this can be a lifesaver.
Excellent. Thank you so much, Dr. Grogin. And if you'd like to learn more about this procedure, please contact our Watchman Program Director, Ann Timberlake. Her name is up on the screen as well as her email address. Her phone number is 831-759-1992. Again, that's 831-759-1992. And her email is atimberlake@svmh.com. Well, that does it for us. Thank you all so much for watching, and happy Heart Month, and love your heart, because we certainly do. Thank you.